Everyone. This presentation is entitled Effect of Enhanced Adherence Package on Early ART Uptake Among HIV Positive Pregnant Women in Zambia, an individual randomized controlled trial. I'm Mwangelwa Mubiana Mbewe from CIDAS making the presentation on behalf of my co-authors. So this work has already been published in the journal AIDS and Behavior. So you can look it up to read the whole manuscript if you like. As a background to the presentation, mother-to-child transmission of HIV is directly related to ART duration. In Zambia, we started Test and Start as option B+ in 2013. And during the early scale-up of option B+, there were issues around acceptance and retention in care which emerged both in Zambia and in other countries which were implementing option B+. So based on formative research which we conducted with patients, community members, health workers, other stakeholders who included Ministry of Health, we developed an intervention called BEAP Enhanced Adherence Package, and we abbreviated it as BEAP to improve uptake of option B+ in our facilities, in 3 facilities in Lusaka. So we hypothesized that when delivered immediately after option B+ eligibility, BEAP would increase ART uptake and augment early adherence in care. So we evaluated this intervention in a randomized controlled trial. We developed the BEAP intervention based on multiple sources, as indicated earlier. We did in-depth interviews and focus group discussions with HIV-positive pregnant women and their male partners who were not necessarily partners of these women. And also we reviewed medical literature and consulted other PMTC implementers, including the Ministry of Health. The BEAP intervention consists of 3 main items, which included a male and female pair of community workers who were stipended and were members of the local communities. Timing in terms of the intervention delivery, where the BEAP counselor attempted to contact participants within 3 days of assignment to BEAP in order to introduce themselves and discuss the services that would be provided, and also optional services which were made available to these pregnant women and their partners. And these optional services included one-on-one counseling regarding HIV/AIDS and maternal and child health delivered at a location chosen by the participant, which could be either in the home, community, or at the health facility. Home couples counseling was also offered to those who were willing. Home male partner HIV testing and male partner referral and linkage to ART for those who tested positive, and appointment reminders by phone call or SMS. So HIV positive ART naive pregnant women were enrolled from 3 facilities in Lusaka and randomized to either the BEAP or standard of care at a ratio of 1:1. And the implementation was from March 2017 to May 2018. The primary outcome for this study was initiating and remaining on ART at 30 days after option B+ eligibility. An analysis was by intention to treat using logistic regression, but we also conducted additional per protocol analysis. The study was approved by both the Unza Breck and University of North Carolina at Chapel Hill. So what were the results? This is showing the baseline description of the characteristics of the enrolled participants. In total, we enrolled 454 participants. 229 of them were enrolled in the BEAP or the intervention, and standard of care, we had 225 participants. Looking at this, you can see that there was really no statistical significant difference between the intervention and the standard of care. The age for the intervention was 26.3 years and standard of care 27.5 years. And we looked at number of pregnancies, average of 3 for both, and gestational age 22 weeks and 23 weeks in standard of care. So, most of the women were either married or cohabiting. And in terms of initiating ART on the same day, at HIV diagnosis. Again, it was similar at 73% for BEAP and 77% for standard of care. Can proceed to the next slide. So for the whole group, the median age was 26.9 years and median gestational age was 22 years. In terms of initiating ART on the same day as diagnosis, we had 75 women initiating ART, and there was no significant difference between the study arms. 92.1% of the women started ART within 7 days of enrollment. So even though not everybody started on the first day, the number had increased to 92.1% by 7 days of enrollment. And within 30 days of option B plus eligibility, we had 98.2% of the women initiating ART. However, only 82.9% were still on ART at 30 days of enrollment, which was the primary outcome. So some women dropped off after starting ART. So we assessed the effect of the BEAP intervention on ART initiation and remaining on ART. And we found that in the standard of care, we had 80.4% of patients compared to 82.5% of participants in the BEAP who initiated and were on ART at 30 days. There was no statistically significant difference in this performance between the BEAP and standard of care. The number of women or patients needed to provide BEAP in order to prevent one early loss from care was 46 in an unadjusted analysis and 37 when it was adjusted for various factors like age and CD4 count and others. We also conducted a per protocol analysis where the women who actually didn't receive the BEAP, even though they were assigned to the BEAP for various reasons, were removed. So we had 136 women who received the BEAP and 125 or 91.9% of these had initiated and were on ART at 30 days. So they had achieved the primary outcome compared to 80.4% in standard of care. So when we did this per protocol analysis, the difference was found to be significant. The number of patients needed to provide BEAP in order to prevent one early loss from care was calculated as 9 in unadjusted analysis and 8 in adjusted analysis. This is just this presentation of the same information in tabular form. You can see in the intention to treat analysis, we had performance at reaching primary outcome, standard of care at 80.4 and BEAP 82.5, and there was no statistically significant difference between these two. But in the per protocol analysis, you see the p-values there for adjusted relative risk is 0.008. So the difference was statistically significant when you looked at the per protocol analysis. So in conclusion, we found that early ART initiation in pregnancy was nearly universal in this population, but there was also early dropout, suggesting need for additional adherence support. We showed a modest improvement in ART uptake among option B plus women using a multi-component community-based intervention. And since BEAP, excuse me, since BEAP is relatively resource intensive, it may be utilized for women identified at most in need of support. Not all the women, I'm sorry. So further research would be useful just to find the effect of this intervention on longer term outcomes, as well as its cost effectiveness. Thank you.